The next technique we're gonna do is cross-fiber friction. The indication of using this is that if there's an adhesion, contracture, scar tissue in the area. The logic is, it's like you're erasing something with a pencil. However, I've seen multiple instructors from work, from school, before that they have different interpretations with this one. I personally would just choose the one that I feel is working in personal experience, but I don't know how you guys were taught with that in school, but the format will be the same. It's just that the method of erasing is a bit different for multiple versions, right? But again, the core will remain the same. So how am I gonna do it? Step number 1, similar as trigger point. I'm gonna use this side for now because I feel bad for his upper back. So what I'm gonna do is I'm gonna do the warm up normally. Okay, warm up. Okay, perfect. I'm gonna see until it's hyperemic again in OSCE or exam, depending on what exam you're gonna take. If they say real time, you gotta do it real time. So if I feel that it's a little bit warmer than the other one, that's good enough. Then I'm gonna try to find the adhesion. So let's say there is an adhesion around the area here. It's gonna feel like a cracking feeling, or like it feels like a little bit of tiny bump. It sometimes feels like a knot, but it's a scar tissue. You'll feel it once you touch it. So, okay. So, John, as I was warming up this area, I found a scar tissue or an adhesion around your lower back. So to treat this, I will be using a cross-fiber friction, which is to help reduce the restriction in this scar tissue. It's gonna be a little bit painful, but I will work within your tolerance. Is that okay? Yeah. Okay. So let me just find the scar. So it's here. I'm gonna lock it in. I'm gonna use my thumb for this. For some people, they use their thumb. You literally use this one. Thumb is good because you can feel more. However, you know, the risk of the thumb. So totally up to you. Whatever you feel works for you, do it. So I'm going to use my knuckle. I'm going to press it a bit. Any pain or discomfort so far? No. No. So let's say I went deeper already. I'm going to remove my other hand so you really see. I'm going to do a cross fiber friction. I'm gonna lock it in. I locked it in, and then I'm doing an X motion. I'm doing an X motion or a plus sign around here. So I'm gonna press it, and then I'm gonna cross. And then I'm gonna move on to the next. I move a little bit, press, and then erase. Okay. And then move down a little bit, press, and then erase. Then go down, then press, and then erase. However, some versions, they're like, fine, some of them do this. Some of them do this.
That's what I remember, kind of, but yeah.
It's kind of a similar thing. The only difference that I think is the other one is a little bit more specific, because I can still do it, see? I can still do it faster, but I'm just doing it like I'm erasing something. So if I'm just exaggerating it, I'm compressing, and then I'm making a big X. Right? And then I would do that until I feel that the adhesions are literally gone, or I feel that it's less. After that, I'm gonna do some flushing. Right? I'm gonna do some flushing, and then I will stretch. Okay? I picked the wrong muscle for this one. I should have went for the QL because it's easier to stretch. The best stretch for this, because that was the erectors, is to do the, reach your toes kind of thing. So, yeah, you can do some stretching out of it. Usually, there's not a lot of scar tissues. It's gonna be around those bigger areas like the QL, rhomboids, levator scapula, those parts. In real life, again, you have to do real life anyway in OSCE or the exam. In real life, what I would say is I would stretch it later towards the end. So what I would do is I would cover him up, and then I would try to let him, I forgot the name of the stretch, but I would stretch his erectors afterwards. If you cannot do this in this position, you can do it later.
Like I would get them to get off the table and everything, or?
No, if we're gonna do it in a tricky way, I'm gonna cover him up. And then can you try to sit, like kneel? Can you try to, like, it's risky because he can be seen. But you know when you sit down, you try to reach, I can't explain it. When you try to reach in front, so you stretch the erectors.
Okay. Like a child's pose?
Yes, maybe that.
Okay.
Yeah.
Would I just tell them I would recommend doing a child's pose stretch like when you get home kind of?
No, I'm gonna do it on the table. My personal with it is because it's a muscle, it's not really a fascia. I would suggest actually stretching it. So that's why in real life, what I would say is that after they change with their clothes, I'm gonna do a full thorough stretching at the end. So I don't have to drape and stretch.
But then in that case, since we're in a station and they're undressed already and stuff, do I have to step out and then like come in all
No, you have to do it on the table. You have to do it on the table. However, I don't want you to panic over this because they're not going to give you something that you cannot stretch or something like that. They're going to give you something attainable, yeah. But like what I said, you learned it at school as this. If you feel comfortable doing that and the patient tells they feel the stretch on that, maybe it is correct. Because again, some instructors teach it that way. So it really feels...
I remember that.
Yeah. But my suggestion is the client tells you, because you've been doing this but they don't feel a stretch, it means it's not the right stretch, so just stretch it. Another thing is I wouldn't suggest that because again, physiologically I don't think it reaches the muscle. But what I would do in this sense is I will turn him over and then do a QL stretch while he's in supine because it covers the area anyway. Okay, let me show you a couple of things that I forgot to show. Let me redrape this again. Because I just remember while we were talking, I forgot discussing about muscle approximation.
Right.
So, put your hands here. Muscle approximation is a good way to use during acute conditions because of the spasm. Muscle approximation is nice to help the muscle contract properly. So for muscle approximation, if I'm gonna do it at the back, what I'm gonna do is I'm gonna anchor one hand here and then anchor the other and then bring it in.
Yeah.
And then hold it until 1 minute and then release. Again, anchor one area, anchor second area, then bring it in. If I'm gonna use the hand, I'm gonna use this version here. What I would be doing is anchoring here, and then bring it in. Because the gist is that you're bringing the actin and myosin together kind of thing. Right? So that's muscle approximation. Again, anchor it here, anchor here, bring it in. Okay, that's muscle approximation. You're approximating the muscle. You're bringing the muscle together. It's kind of similar concept with GTOs and OSCEs, but instead of like targeting the origin and insertion, you're targeting the bulk. You're bringing the bulk manually, right? Okay. So let me show you a couple of GTO techniques. So for this one, for GTO techniques, the difference is if it's an origin or insertion technique. The thing is that it's going to be you pin the origin and you do an X marks, right? As what we have discussed earlier. It's like fiber friction but on the origin and insertion. The point is if the muscle bulk itself does not react properly, then you use the ends of the muscle to make it relaxed. That's the gist. So I'm gonna show you a couple of spots here. For GTO, you can do a pulling sensation or you can do C bowing or S bowing on the tendons that you can do, like the, like the Achilles tendon on the foot or even here on the top. So for example, we have around here, we have the rectus rectus capitis muscles, the trapezius muscles origin. If the muscles around here are not really reacting, what you can do is find the base of the skull. So I'm now on the base of the skull here, and then I'm gonna use my fingertips. Don't do this, like grab it, anchor it a bit, and then pull. Take a deep breath in, and then out. So as he breathes out, I'm just anchoring and pulling it up. Do you feel any pain or discomfort here?
Yeah.
And then, is it tolerable?
Yeah.
Okay, since it's tolerable, I'm gonna hold it until you feel that the tension is less. Similar with trigger points, you wait until it feels better. Okay? If we wanna do O's and I's here, it's gonna be similar, but instead of pulling, what I would do is I would find the origin. So right now, it's here, and then I'm just gonna get my fingertip, take a deep breath in, keep breathing in and out, okay? And then out. So I'm just gonna do an X motion around the area. Is it painful?
Yeah.
Sorry, I'm gonna go lighter. So there, I'm just doing an X motion. If I'm showing it here, I'm just literally pushing and then making an X. That's how it looks like to me, at least.
So not SIBO or ESBO?
No, that's another version. That's another version of it.
Oh, okay.
Okay? So let me go towards, let me see if you can see it. If I'm gonna do it on the Achilles tendon for GTO, I will just grab the Achilles tendon and make a C bow
Yeah.
or an S bowing and hold it until you feel that the restriction is less.
And that's GTO still.
Yeah.
So it's just a different type.
Yeah, origin and insertion technique is a GTO type. It's just that it's used on areas that doesn't have prominent tendons like this. So if you cannot do C bowing, S bowing in that, then instead of doing the GTO, do the origin and insertion technique, where you either pull it or you do the cross-fiber friction. Like for example, in the neck, it's kind of hard to do it there because there's not a prominent tendon. So what I did is I did the cross thing. So before I turn him over, just as a review, I'm also gonna try to show you how to drape a high glute drape and the regular leg drape.